Hi, everyone. Thanks so much for joining and being on time. I'm just going to give it a couple more minutes to see if anyone else hops on, and then we'll start. Hi, everybody. I am Dr. Vinita Tandon. I am a board-certified endocrinologist, and for the past few years have been the medical director of the bioidentical hormone replacement therapy at Jumpstart MD. Hi, Dr. Burke. How are you? I am going to go ahead and just start in a couple minutes. Thank you so much for joining us. I also have a special guest, one of my patients, Caroline, with us today. So Caroline, thank you so much for joining too. I definitely want to keep this talk informal, and feel free to ask any questions along the way. You can use the Q&A tab. I'll try to get it to in real time, otherwise definitely by the end of the talk. And let me start sharing my screen here. All right. So today's topic is really just the basics, kind of Menopause 101. And, and the reason I thought this topic was important was so many times we hear patients come in and really had no forewarning about what symptoms they were about to experience when they transitioned into menopause, and felt a little bit like they didn't get the guidance or education that maybe they would have benefited from their outside providers, and just to have kind of heads up about what changes to look for when they kind of enter that perimenopause, menopause age. So we just want to talk about basics today, go over a little bit about some definitions, signs and symptoms of menopause, and then a little bit about treatment. I have, I think, 2 more talks scheduled after this. And those talks, I'm going to go a little more in depth about treatment. Also talk about kind of the older studies that scared everybody about breast cancer risk. We'll talk about the newer data, the newer treatment options. So I'll go into more depth about treatment in future talks. So just know that. But if you do have some questions today, that's fine. The content, though, will stay kind of more on signs and symptoms of menopause and what to expect, and why those symptoms happen. What's the cause? Caroline, I'm speaking on behalf of Caroline, but both of us welcome any questions along the way. So feel free again to use that tab. So before I go on, we had a great promotion earlier in June, which was super successful. So we decided to carry it through to the end of August, and feel free to take advantage before it expires. But basically, if you are interested in having your hormones evaluated, having a consultation with one of our BHRT clinicians, then please take advantage of the program. You get a 1-hour consultation, and if you sign up for that, it's $285. We pay for all of your hormone labs to be drawn, and that retails for a $600 to $900 value. So it's a huge, and that will expire August 31st. All right. Okay, so what is menopause? In general terms, it marks the end of a woman's reproductive years, which means that she can no longer have a biological child. And it can occur suddenly if a woman has had surgery to remove her ovaries, but for most women, it is just kind of a natural part of aging. And the textbook definition is when a woman has not had a period for 12 consecutive months, she's considered to be menopausal. And the word pause is purposely put in that term because it really is a sudden pause where your ovaries abruptly stop working, they stop producing eggs, they stop producing important key hormones, and that leads to a cascade of signs and symptoms of menopause. For an American woman, the average age is about 51 to 51 and a half, but the age spectrum can be anywhere from your early 40s to your late 50s. So I've had 42-year-olds go into menopause, I've had 58-year-olds go into menopause, but kind of the mean age is 51. There have been numerous studies to look at if there are any predictive factors of when a woman will go into menopause, and nothing really has panned out. The only kind of soft, loose correlation seems to be with mom's age. So if your mother went into menopause in her late 40s, maybe that predicts you may do the same. But I definitely emphasize the word loose correlation because we've had women who they say their mom went into menopause at 55, but they went into menopause at 45 and vice versa. So you are like, if you're older than 45 and you've already skipped 3 periods in a row, then there's a pretty good chance menopause is around the corner. So that's kind of a clue that you're headed in that direction. So perimenopause is the time period around menopause, and that can start anywhere 8 to 10 years before actual menopause. And many women don't realize that some of the symptoms they start to experience in their late 30s and early 40s are due to that hormonal change that's happening. And because it just seems like, oh, it's too early, but it actually isn't. Many of the signs and symptoms of menopause actually start in perimenopause. And because already the ovaries are starting to change their production of estradiol and testosterone. So you start to see a kind of a gradual decline in perimenopause, but it's really usually the 1 to 2 years right before menopause that the symptoms intensify. And that's because estrogen dramatically drops at that time. But you can still have occasional ovulation. You can occasionally still release eggs. So you still have the ability to get pregnant. And periods can be either regular or irregular. Some women have regular periods all the way up until it completely stops. Other women start to have signs of irregular periods before they completely stop. Another classic thing that happens in perimenopause is the PMS week or 10 days that can worsen, where women have even more moodiness, more bloating, maybe some insomnia, poor sleep. That seems to intensify during this perimenopausal period. This is a nice graph the Cleveland Clinic produced, and it just depicts what happens with the hormone levels. So when you're in premenopause, all the way up until your early 40s, your hormones tend to be nice and high. But then you can see there's a dramatic decline, a steep slope down where estrogen and progesterone really precipitously fall and stay that way until kind of your mid 50s. And then they just bottom out and they stay bottom indefinitely. Postmenopause is basically from menopause till the day you die. You're postmenopausal. and it's the stage after menopause. This is the time period where we get all of the quote unquote old age problems. We're at risk for certain medical conditions like heart disease, osteoporosis, hip fractures. Some of the symptoms that were super intense before may get a little better during this time, but many symptoms don't improve at all. Women continue to have mood changes, continue to have poor sleep, may continue to have foggy headedness, low libido, vaginal dryness, and they only get relief when we optimize those hormones again. So the key hormones that we lose in menopause are estrogen, progesterone, and testosterone. And all three are predominantly produced by our ovaries. And so that's why when our ovaries stop functioning, these three key hormones drop so much, leading to all of these signs and symptoms of menopause. So you can see it affects everything. Your mood, women complain of more anxiety and depression. We'll go over that in more detail. Some women complain of headaches that are new. Definitely decreased libido, which is also associated with vaginal dryness. They have pain with intercourse. They gain weight, especially in the midsection, more belly fat, hot flashes, night sweats, insomnia. They have poor energy. Before they were maybe just a high energy person, were able to multitask, juggle numerous things, and now they really feel like they can't handle much at all. And again, many women don't realize that this is due to hormonal changes. They attribute it to life stress, work stress, having kids, elderly parents, whatever it is, and don't realize that a lot of the root cause of these symptoms are due to the decline of these hormones. Some of the additional, little bit less common symptoms women may notice are breast tenderness, joint and muscle aches. Few women have told me that they just all of a sudden will have episodes where their heart is racing, and whether they're awake during the day or they're trying to go to sleep at night, it's just random episodes of what we call tachycardia. Dyspareunia, which is pain with intercourse, that's a common symptom, again, due to the vaginal dryness. And women may notice urinary symptoms where they frequently have to urinate, but they don't get complete voiding each time, and maybe a higher risk of urinary tract infections. And again, that's because of the loss of estradiol. The vaginal epithelium isn't as healthy. It's more friable, dry, so bacteria can easily enter, and they get frequent urinary tract infections. And all too commonly, they will say, oh, my doctor put me on antibiotics, and they may be on a course of antibiotics every few months for this reason. And again, if we had just gotten to the root cause and improved their estrogen levels, they wouldn't be needing the antibiotics so often. So what is a hot flash? Women sometimes don't know what it means to have a hot flash. The textbook definition is when you have a sudden feeling of warmth, especially in the upper body. And it's usually most intense over the face, neck, chest. It may be accompanied by reddening of your skin and then sweating. So some women, if they sweat too much, they actually have chills after. And the theory is that it's not, we can't confirm it 100%, but the theory is that basically the thermostat is off in menopause. And so even with small, minor temperature fluctuations, the hypothalamus may think that the body is too warm, and it kind of causes this hot flash to cool you down. And so, but then if you have too many of those, you actually alternate between hot, cold, and you can do this frequently throughout the day without any warning. We used to think that the hot flashes just persisted maybe the first 5 years of menopause, but now data is showing that in the majority of women, symptoms persist actually 10 to 20 years after the onset of menopause. And about for 25% of women, it may go on indefinitely. Maybe not as frequently as when they first were in menopause, but they will occasionally continue to have these vasomotor changes. And it's some of the hot flashes can be mild, where women will say, oh, I'm able to ride it out. It just bothers me for that minute and then I'm okay. But for a significant portion of women, it is debilitating. All of a sudden, they may be trying to give a talk in front of their teams or give a presentation, and all of a sudden they're getting red and sweaty, and that's very bothersome. Night sweats is closely associated with hot flashes, again, due to decline in estrogen. And this typically happens at night. Repeated sweating, repeated episodes of excessive perspiration, and to the point where some women may notice that their pajamas are drenched, their sheets are drenched. They actually have to wake up in the middle of the night to change their clothes or change their sheets. And again, they can alternate between hot and cold. The one minute they want the covers, the next minute they want the covers off, and they're just restless all night long, covers on, covers off throughout the night. Vaginal dryness and pain with intercourse are two underreported symptoms. It affects at least 50% of postmenopausal women, but almost up to 90% of women don't seek treatment for it. And whether that's because it's a topic that they're shy about addressing, or whether they don't really realize it's due to a hormonal change, they unfortunately are kind of silent sufferers in this regard. And it's only when we talk and ask these questions does it come out that they've been experiencing these symptoms for a while. And again, it's due to the atrophy of vaginal tissue, which becomes thinner, drier, less flexible, and again can lead to frequent urinary tract infections and pain with intercourse. And pain with intercourse is very closely related with low libido. So independently, when women go through menopause, they notice a decline in their sex drive. They may have had a nice, robust libido before menopause, and now it's kind of take it or leave it. There may not be the initiators anymore. It can cause tension in their partnership because their partner then has to always initiate. The partner may feel rejected because the woman isn't really interested. It can also be a vicious cycle with the vaginal dryness and the painful intercourse. They just don't find pleasure in intimacy anymore. So it's one thing we definitely address. And one of my patients, she gave me this quote, "A shag a day keeps the therapist away," because her husband told her that, they were going through marriage counseling, and after her libido was restored, their intimacy improved and they were able to stop their counseling. So I think we sometimes maybe don't realize how important libido is, and many women dismiss it as a symptom. But when it's restored, it's amazing how their quality of life can change and their marriage or partnership can improve. So weight gain is almost a given with menopause. You gain weight in general starting in perimenopause, and then it can worsen when you get deeper into menopause. It typically tends to settle in the midsection. So definitely if you maybe had more weight in your thighs or butt area, now you'll notice a little bit more predisposition to belly fat. And this kind of is a multifactorial thing. You have lower metabolism with the decline in hormones, less active because the hormones are down, muscle mass diminishes. So overall, women kind of describe it as feeling more fluffy and soft. They've lost muscle tone. And insomnia is another reason why you can gain weight. When you don't sleep well, it sets you up for low energy the next day, so you don't feel motivated to exercise. It reduces your metabolism independently. So it just kind of sets you up for weight gain. There was an interesting study called the Healthy Women Study, and this was quoted by the North American Menopause Society. They're kind of the thought leaders in menopause. And what they found was that the average weight gain in perimenopausal women was about 5 pounds, but up to 20% of the population actually gained 10 pounds or more. That's huge. If you have made no changes in your diet or exercise, and then all of a sudden you've gained 5 to 10 pounds, that can be very frustrating. It affects your body image, it affects your confidence. It may take you up a size in your clothes, and that doesn't feel good. And again, women don't realize that this is all hormonal. They found that the prevalence of obesity, which is a BMI over 30, reached 65% between the ages of 40 and 60, and almost 75% in the women over age 60. This is in American women. So during menopause, the drop in estrogen leads to increased body fat, especially in the midsection. But another interesting, a few studies actually showed this, is that an interesting change that happens is you have an increase in your hunger hormone in menopause. So you're just more hungry, you have more cravings, and you have a decline in your satiety hormone. So it takes longer for you to feel full. So both of those, it's like a double whammy, and sets you up for just, again, eating more, plus you're less active and you end up gaining more weight. So over half of menopausal women complain of poor sleep. And for everybody, the definition of poor sleep is different. Now, with more and more Fitbits and other devices that people are wearing at bed, they can really track their sleep patterns. And women will show me, their graphs and say, oh, well, look, before menopause, these were my graphs, and I was getting good deep sleep for a good portion of the night. And now after menopause, I'm barely going into deep sleep. Women notice that they don't even dream as much when they go into menopause. The usual complaint is that they're able to fall asleep, but they can't stay asleep. So they're constantly tossing and turning all night long. And that's what the data shows too, is that women now all of a sudden stay in a very superficial zone of sleep. So they easily awaken and then they have to put themselves back to sleep. And they just keep doing this all night long. Some women are very good about not turning on their phones or getting on their laptops. Maybe they'll use like a meditation app to put themselves back to sleep, or some kind of calming thing. But many women, once their brain wakes up, it's very hard for their brain to shut back down. And so they end up only getting a few good hours of sleep at night. And again, that just wreaks havoc the next day, where they have more fatigue, metabolism is down, they have more sugar cravings, no energy reserves, they feel completely unrestored in the morning and the rest of the day. And so what we really try to do is break that cycle. And by restoring their hormones back to the premenopausal range, it restores a good night's sleep. Mood changes can be subtle and sometimes not so subtle. Women may notice actually a change in mood starting in their 30s, early 40s, in that perimenopausal stage. And it's the decline in estrogen which leads to a decline in serotonin. And serotonin is a really important mood neurotransmitter and mood stabilizer. And women may notice that their mood fluctuates. They have kind of this happy high 1 minute, and then they're crying the next minute. And they are cognizant of the fact that this is so bizarre, but they don't have control over it either. They just know that this is so unlike themselves. And oftentimes they'll seek help from their primary care providers, and maybe they get a prescription for an antidepressant or an anti-anxiety medication. But again, that's just a Band-Aid. It doesn't really address the root cause. And once we fix their hormones, many of them are able to go off of their antidepressants or anxiolytics. Anxiety is another common complaint. It can be mild, but women will say that, they never had a fear of flying. They never had a fear of driving on a highway, a fear of socializing at parties or public speaking. And now they do feel anxious, which is a change for them. And they just have a little underlying panic when they get on a flight, or again, driving on a highway, or meeting up with friends and having to socialize. So it can be subtle or it can be drastic, but it can definitely affect your quality of life. And women who have a history of severe PMS in their premenopausal years tend to be at a little higher risk of more mood disturbances in menopause. And definitely women with a history of depression are particularly vulnerable to recurrent depression in menopause. So something to be aware of. I just love this picture. I think my kids would say that all of my brain areas are quite active, eye rolling especially. But these are, it's funny but not funny, because actually, this is what happens, that women do lose their sense of control, their stability, their emotional stability. Change in cognition is another thing that can happen, where women notice that they feel more foggy, easily distracted. They may have difficulty with word and name recall. Somebody that they work with and they should have no problem remembering their name, all of a sudden the name can't come to them. They don't feel like they're on their game anymore. They feel just foggy. And brain, we know, is a very important target organ for estrogen. So it's no surprise that when estrogen declines, the brain is impacted. Many of our women are very and justifiably worried about getting Alzheimer's. And this may be because they have a family history of Alzheimer's, or it's just something that's on their mind, or they panic when they do have a decline in short-term memory and they wonder if it's a sign of Alzheimer's. Alzheimer's is more prevalent in women. About 2 times more, women are 2 times more likely to die from Alzheimer's than men. And the hypothesis is that it is due to an abrupt loss of hormones in women. I think women, we tend to focus so much on breast cancer, but the truth is that for every woman diagnosed with breast cancer, 2 are diagnosed with Alzheimer's. And with breast cancer, at least there's a cure, there's treatment. With Alzheimer's, there's none. And so that is something that we definitely address in terms of hormone optimization. And estrogen is one of the hormones that can reduce the risk by almost 25 to 50%, depending on the study that you look at. Metabolic syndrome is kind of a constellation of signs. It's associated with central obesity. So again, having more belly fat outside the belly as well as inside the belly, surrounding all your organs, insulin resistance, and then abnormal cholesterol. It is associated with high blood pressure, kind of having a hypercoagulable state, which means you're more predisposed to blood clots, and pro-inflammatory states. So you have more inflammatory markers. And being in menopause is associated with a 60% increased risk of metabolic syndrome. And we know that about half of all cardiovascular events, which means heart attacks and strokes, are related to metabolic syndrome. So if we can restore those hormones, we would drastically reduce the risk of metabolic syndrome and then the risk of cardiovascular disease. So after menopause, a woman's risk for a coronary event equals that of a man's, because she loses all her protection of estrogen. And we see that there's a huge rise in heart attacks about 10 years after menopause. And so that sudden drop in estrogen leads to a rapid acceleration of cardiovascular disease. And in westernized countries, cardiovascular disease is the primary cause of death. More than 1 in 2 women die from cardiovascular disease. And again, we sometimes focus so much on breast cancer, but in every decade of a woman's life, the incidence from heart disease is much greater than the incidence of breast cancer. So that's what we need to focus on. We need to improve women's risk for developing heart disease and improve their longevity. Oops. So hormones, estrogen, testosterone, they both have a huge impact on our bone health. And when estrogen drops, we have an increased risk of osteopenia, which is just a precursor to osteoporosis, an increased risk of hip fracture, and an increased risk of kyphosis, which is kind of that hunchback look. The National Osteoporosis Foundation quotes that of the 10 million Americans with osteoporosis, 80% are women. And approximately 1 in 2 women over the age of 50 will break a bone because of osteoporosis. And again, just kind of relating it to breast cancer risk, the risk of breaking your hip is equal to the combined risk of breast, uterine, and ovarian cancer. And in any given year, there are as many women who die of hip fractures as breast cancer in the US. So again, we are trying to avoid osteoporosis. The beauty of estrogen is that not only can it help prevent osteoporosis, but it can also help treat osteoporosis. So I'm going to stop here for just a second because I'm going to give Caroline the mic. And let me see if I can do that. Caroline, are you able to unmute yourself?
Yeah, I just did.
Oh, good. Thank you. Thanks for joining us.
No, thank you for doing this. This is really educational, really helpful for us.
Oh, good. So I just was curious if you wouldn't mind kind of sharing what symptoms you noticed when you transitioned into menopause and what things made you seek treatment.
Well, one of the things that I definitely had the hot flashes, but for me, they would hit me every morning as I'm driving into work. All of a sudden, I'm just breaking out and sweating like crazy, and my hair, which I just blow dried, is now completely drenched. So
Right.
that would just drive me crazy. I'm like, what is going on? So I'd open up all the windows so that way I could dry off again, but it was really crazy. And I was always feeling very anxious and irritable and on edge, and at work where I'd be able to concentrate on something, all of a sudden, it's like I wasn't able to focus and I'd get easily distracted. But I think what really impacted me the most, and I blamed the fact that I wasn't able to concentrate on the fact that I was having to wake up at least, 4 times a night, every couple of hours, and I'd be constantly going to the bathroom, when in the past, I would sleep like a rock. Nothing would wake me up. I would sleep through earthquakes, literally, So when all of a sudden I'm waking up like 4 times a night, luckily, I was referred to you, Dr. Tandon, and you're like, Caroline, I think this can help you. And for me, the fact that I'm able to sleep through the night now, and I very rarely, maybe I would say every 3 or 4 months, maybe once or twice wake up at night, maybe 1 or 2 times that entire time period versus every single night. This has been a miracle for me. This has just been amazing. I feel like I have my life back. And for me, that is frankly just invaluable. And thank you so much for, educating everybody. And so that way they too can understand that there really is hope and this really does work. And there's no replacement for this.
Right. I'm curious, did you ever seek treatment from like your primary care? Was there any guidance that way in terms of, giving you some forewarning that this is due to menopause? Here are some options.
No, they would say they had me do like a sleep apnea test, and that only showed that, yeah, I did have a, mild version of that, but, that really still didn't help me to be able to sleep through the night.
Yeah. I know it's kind of it's funny how dismissed hormone imbalances are by the medical community.
Exactly. It's shocking.
It is. They actually did a study looking at, they actually interviewed medical residents, internal medicine residents, and asked them, do you feel ready and confident to manage menopause? And more than 60% said they had no education in menopausal treatment, counseling.
Yeah.
So
that's
thank
where,
you.
what you're doing here, this is frankly invaluable, just to become aware of it, and just to, when I was pointing towards you to say, hey, you might want to just have a consultation with her, that was such an eye-opening event. And frankly, it's like, I'm able to focus again at work. I'm able to be productive. I'm not irritable and cranky. And, it just makes my, the quality of life is just so much better now.
Good. Yay. Thank you so much. And if anyone has any questions for Caroline, I'm sure she'd be happy to answer.
I would.
Yeah. You're the best. So yeah, like Caroline said, hormone therapy is our hope and the treatment that we recommend. I'm gonna mute. It is what reduces hot flashes and night sweats when we restore estrogen, reduces the vaginal dryness, improves mood, improves cognition, improves energy, aches and pains go away, improves libido, improves partnerships, and it improves body composition, where we see a reduction in body fat, and an improvement in lean muscle mass. It also has a huge impact on health and medical risks. It decreases the risk of osteoporotic hip fractures by 50%, helps prevent Alzheimer's, reduces the risk of heart disease, reduces the risk of incontinence, urinary tract infections. Data shows it can reduce colon cancer, reduces that midsection visceral fat, belly fat, improves blood sugars, improves lipid profile, improves lean muscle. So it just affects almost every cell of your body in a positive way. So again, I just kind of wanted to emphasize the risk of heart disease because I think that we underplay that a little bit. We focus so much on the C word, the cancer. And just to put it in perspective, after the age of 55, the risk of dying from heart disease is 7 times more than the risk of dying from breast cancer. And heart disease kills more women than the next 16 causes of death. And to help reduce that risk, hormone therapy improves your lipids, it improves your insulin, improves your glucose, reduces your belly fat, improves your energy so you can exercise, so you can have discipline over your diet, improves your mood, all of those things. And the goal is to improve your health span and lifespan. There was Estrogen Matters is a great book I would recommend to anybody who's considering hormone therapy or wants kind of a more in-depth analysis of hormone therapy. It's actually co-written by an oncologist. And what they did a statistical analysis. And what they wrote is that if every woman in the US took hormone therapy, the lifespan would increase on average by 3 years. And in 2002, a study was published called the Women's Health Initiative that showed that the synthetic progesterone that they were using at the time had a link with breast cancer. So everybody stopped prescribing hormone therapy because of it. We don't use that progesterone anymore, but still people are not prescribing hormones. And the statistics show that that because women were taken off their hormones at the time, about up to 50,000 women may have died from premature heart disease because they were taken off their hormones. So that's huge. That's a huge number. And now we're trying to re-educate both providers and patients about the benefits of hormone therapy and the safety. And that will be kind of my next talk. We'll just be diving into this study and subsequent studies talking about safety of hormones. But somebody asked me, they sent a question yesterday whether they could use hormones even though they're a couple years out from menopause. And yes, the answer is yes. Hormone therapy is best if you start it soon after menopause, but that window is within 8 to 10 years. You get the maximum benefits in terms of reducing mortality and heart disease. But even if you're beyond 8 to 10 years, we have many women who are in their late 60s and 70s who are seeking some combination of therapy for certain symptoms, and they are candidates as well. We use bioidentical hormones, and because they're molecularly identical to our own inherent hormones, they're preferred, and they're usually plant or soy-based. And so again, it's something we individualize and customize for every individual, depending on their quality of life symptoms, their medical conditions, what they're seeking, out of the treatment. But like Caroline said, we hear this all the time. It gives women their life back. And Dr. Berg, you've been doing this longer than me, but maybe you also have any anecdotal stuff or comments. I think everyone's so grateful that we even have this program.
I thought you did a great talk.
Thank you.
Very comprehensive. So I thought that was fantastic. I would echo, what Caroline, I think, expressed, that as a practice, it's a very, very gratifying practice in medicine because you're doing so much to improve both quality of life and to mitigate really important downstream health risks. And just like you described, the big 3 being kind of heart attack, stroke, Alzheimer's, and yes, osteoporotic fractures. And as someone who spent 15 years in emergency medicine, treating all kinds of osteoporotic fractures, from the hip fractures that have significant one-year mortality because of all the things, complications associated with it, or low back fractures or wrist fractures, or whatever it might be.
Yeah.
This is such a powerful intervention that can really improve both those downstream health risks, which in general is not the reason people do it. They're really looking to improve near-term quality of life, which is another wonderful reason to do it. But it's such an unusual aspect of medicine, I guess, where you really feel like you can play offense and not be constantly kind of on the defense, just trying to put Band-Aids on things, but really trying to be proactive about helping improve people's well-being, quality of life, to your point, relationships. I used to jokingly say, hey, this is couples therapy. Like, you don't need to pay that psychologist. You just need your hormones adjusted, and often, again, as a couple rather than as an individual, because it can be so beneficial for a relationship, for all the reasons you described. So I don't have much to say other than I love the practice. Like, it's just been super gratifying. So I don't get to do it as much as I used to because of you.
Oh, we can rope you in anytime.
Yeah, I love it when I do.
No. It looks like we have a couple questions. So one
There's
is
one hiding too, just so you don't miss that one. I had typed a response in the column that was the first question that came through.
Okay.
The answer was, see if she answers it, and if not, maybe if you touch on the answered column.
Okay, yes. So if you are a breast cancer survivor, can you still be a candidate for hormone therapy? And the answer is yes. We would take a thorough history, and depends kind of where you are in that journey, what hormones you would be a candidate for. But we are working with many oncologists who are sending their patients as well, because depending on the treatment, some of the breast cancer treatments can really even further worsen menopausal symptoms. And so they're definitely seeking some hormone optimization to help with those quality of life symptoms. Even if the cancer was estrogen and or progesterone positive, we work with you and your oncologist to find kind of a safe and effective solution. So it's definitely worth a consultation to talk to your clinician about it.
I don't know if you'd add one thing to that, and just as a question. In general, our practice in the past had been, hey, we wanted people to be breast cancer free or in remission for at least 5 years to be candidates for therapy. Dr. Tinden might be able to make exceptions for that in more complex kind of cases, but as a rule of thumb, I'm kind of wondering if that's still your practice, but that was my practice historically.
Yeah, I think the testosterone therapy, sometimes we do earlier, depending depending on their symptoms, but especially because testosterone has good data that it may be an anti-cancer hormone. And sometimes we can at least bridge you until you are 5 years in remission, like Dr. Burke said. The next question is, I just stopped my microgestin, having been on since after my 23-year-old was born. I'm planning the blood work for BHRT on September 16th to clear my system. Is it possible that my decreased libido and vaginal dryness may improve in these 8 weeks, or will I likely not see changes until I begin any hormonal optimization from my potential treatments? Good question. Yeah, you may have some improvement being off the birth control. We know that chronic use of birth control can reduce libido. So once you're off of it and it's cleared out of your system, you may have a little pickup in libido. Vaginal dryness is plus or minus, not sure, but when we optimize your hormones, yes, vaginal dryness will definitely improve and libido will improve further. So hard to say until you've been off of it for a little bit. All right. Oh, how does exposure to xenoestrogens and BST and dairy affect hormones in the onset of menopause? I briefly looked at this many years ago to see what hormonal effects there were, because there definitely, there's been a change in even young girls when they enter menarche. It used to be they were over the age of 13 when they had their first period. Now that age has dropped by almost a year. Now they're just a little over 12 on average when they have their period. So there's been a lot of questions about whether there are certain, in dairy products or BPAs, what are some of the things that may cause these endocrinopathies. The data when I last looked at it was so really small studies and not very well validated. I can look again and do another literature search and get back to you, but from my recollection, I remember thinking that there was nothing clear cut that said one way or the other whether these exposures affected the onset of menarche or menopause. So hold on to that question, and I can see if I can do another literature search and see if there's anything new on that. Anything else?
I have a geeky question.
Yeah.
How specifically, and this may be too broad of a question, but does estradiol protect your bones, your brains, and your heart? Because it's fascinating that, as an example, like as a premenopausal woman, you're at lower risk of heart disease than a man. But as soon as you enter a low estrogen state as a menopausal woman, then suddenly your risk goes up to a man's level of risk. So any sense of how that's working specifically to try to protect heart vessels, and then by brain vessels in the same way, I assume, and then Alzheimer's is probably a different mechanism, but
right. I think so. For the cardiovascular risk, it seems that estrogen helps improve LDL, the bad cholesterol, improves the good cholesterol. Also, the small atherogenic LDL, estrogen reduces those. So you basically get reduction in plaque buildup. In terms of bone health, it helps with the turnover of each bone cell. So there's always bone cells that are growing and bone cells that are dying. And estrogen helps alter that ratio. So you get more bone building and less bone destruction. And we used to give it much more freely for osteoporosis, and then some newer osteoporosis medications came out on the market, and so people started prescribing that. But there's so many pitfalls with those medications that now more and more women are coming back to hormone therapy, because not only does it help with the bone health, but they also get all these other quality of life benefits and cardiovascular benefits. For the Alzheimer's, I am not actually sure the pathophysiology of how estradiol works and to reduce Alzheimer's risk. And there's some theories floating around how it even when you go into menopause, why that exacerbates the Alzheimer's risk. But I don't know, except for some animal studies, whether they really have an idea of the mechanism of action.
And does progesterone amplify the effects of the estrogen, or otherwise somehow synergize to make that even a better risk reducer around stroke risk, Alzheimer's risk, osteoporosis risk?
That is a good question. Most of the studies I looked at were mainly talking about estrogen independently. So I don't know if progesterone does act synergistically and kind of help enhance those benefits. We give it anyways in anyone who's on estradiol, but yeah, I'm not sure if there's a synergistic effect.
Thanks.
Yeah, you're welcome. Thank you. Thanks everyone for joining. And please, email or call for any other questions. And yeah, thank you. Have a great rest of the week.